Hi, everyone. So I'll be discussing, after that excellent presentation by Dr. Mansour, some of the challenges we face in diagnosing SIH. And Dr. Mansour already touched on some of this already. Some of the disability that we see related to this condition and some of the recent studies that have looked at that, and some of the complications that we can see with this condition that, again, Dr. Mansour has already discussed a little bit. So just in terms of the objectives, we'll discuss some of the challenges in SIH diagnosis and some of the concerns we have with the diagnostic criteria that are currently available. The differential diagnosis, particularly looking at orthostatic headache. The utility of lumbar puncture opening pressure, because that question comes up all the time, like is it useful to do an LP, and how much value is there to that opening pressure. We'll discuss the disability and quality of life associated with this condition, some of the potential long-term complications, and why a diagnosis should not be missed. So first off, why is this condition challenging to diagnose? And Dr. Mansour already alluded to this, but unfortunately, it's difficult because the symptoms can overlap with a number of other headache conditions. So that's already challenging right off the bat, that it can look like some of the other headache conditions that we see. So, very common for it to be misdiagnosed. The second issue is the current diagnostic criteria are specific. So if they're present, it certainly means the patient does have that condition. But if those criteria are not present, it doesn't necessarily mean that the patient does not have SIH, because unfortunately, some of these diagnostic criteria that we're using currently lack sensitivity, and they need to be updated. The other thing is the imaging, of course. So we know that approximately 20% or so of patients at this time can have negative MRIs of the brain or spine, and so it can be challenging. When they have negative imaging and they may not have a classic presentation, then it's very easy to misdiagnose that as well. So essentially, a very high degree of clinical suspicion is required to diagnose the condition. But when the condition is diagnosed, patients can also experience significant barriers to care. And we know that there's long wait times for them to see specialists or be referred to specialty centers. And there's also limited access, unfortunately, to some of the procedures they need, to some of the diagnostic imaging that they need. And Dr. Hoydonks will elaborate on this further in a Canadian survey that we did that actually looked at that. So let's talk about the diagnostic criteria and some of the issues that we have with that. So first off is the ICHD-3 diagnostic criteria, which is essentially the most prevalent, I think, that's used for the diagnosis of this condition. And you can see there that point B, which is low CSF pressure under 60 millimeters, or evidence of CSF leakage on imaging, is an issue right off the bat. Because, again, as we'll discuss, opening pressure can be normal in many patients, in fact. It actually seems to be the more prevalent thing that we see is that they have normal opening pressure. And again, imaging is not always positive, or it could be very subtle, so it could be missed at times. So again, it's difficult to make this diagnosis because this criteria is not sensitive enough and needs to be updated. In regards to the Dr. Shivink diagnostic criteria, also, good at the time, back in 2008 when it was published, but, the discovery of CSF venous fistulas actually was after that. So it's been about 10 years that we know about CSF venous fistulas. So again, some of these diagnostic criteria that are there were from the past and need to be updated. Again, opening pressure is not going to be under 60 or 6, in all patients. It's going to be normal in many patients. There's not always going to be imaging evidence on MRI that there is spinal CSF leak. And also the point of improvement after epidural blood patching. Again, we don't see that in all patients that have spinal CSF leak. There are certain types of leaks, for example, ventral dural leaks that are more chronic in nature, where conventional blood patching will not be that effective. So we do have to keep in mind that, unfortunately, these diagnostic criteria all need to be updated, and hopefully that will occur in the coming months to years. So what about differential diagnosis for orthostatic headache? So in regards to the differential diagnosis, these are some of the common things that we see, so we'll focus on those. But as neurologists, certainly we're going to see patients that have other non-spontaneous forms of spinal CSF leak. So again, important to ask on history, as Dr. Mansour mentioned, whether there's been any trauma to the head or neck. Important to ask what procedures or surgeries have been done in the past, again, because of iatrogenic causes or post-dural puncture headaches that we can see. So things like lumbar puncture in the past, epidural anesthesia or spinal surgery. And these can be years in the past or months in the past. So just taking that careful history to see when the procedure was done and when the symptoms started. The second is cervicogenic headache. Again, we can see orthostatic type of headache with that as well, and I'll get into that in a little bit more detail. And then postural orthostatic tachycardia syndrome, or POTS, is another common one where, again, we can see overlap. And then there's some less common conditions that we can see also, like things that affect the spinal lumbosacral dural compliance that can affect patients in the same way, in that they can have that orthostatic headache but don't truly have an underlying CSF leak. Sometimes orthostatic hypotension as well, because patients have that lightheadedness or dizziness when they get up. But these tend to be differentiated often more easily. So I think the ones that are kind of our major difficult ones where they can overlap a lot are kind of those first three. So we'll delve a little bit more deeply into cervicogenic headache and POTS. So in regards to cervicogenic headache, this is a group of cervical spine disorders that essentially refer pain to the head. And they're often caused by pathology that's related to cervical structures, particularly innervated by the C1 to 3 nerve roots, but it can be lower down in the spine as well, but those are the predominant ones. And the potential sources of pain can be from joints, like the atlanto-occipital or other ones, the nerve roots, the joints as well, and the cervical nerve roots. Some of the common pathologies include degeneration and inflammation of the cervical spine. And upright posture tends to worsen that because there is that loading, axial loading that occurs with the head in that upright position, the weight of the head. So ways to differentiate that, in that patients will often have worsening with neck movement or any manipulation of the neck or provocative maneuvers. And they also tend to have a restricted range of motion with that as well. So again, those are helpful to differentiate this from SIH. So in regards to the ICHD diagnostic criteria, you can see what's listed there, but essentially it's a headache that's correlated with the timing of the cervical spine disorder, and it either worsens or improves with the underlying cervical spine disorder. Again, there tends to be restricted range of motion, and it worsens with provocative maneuvers. And then in regards to postural orthostatic tachycardia syndrome, so this is an autonomic disorder, and commonly we see people that have this in the females that of reproductive age, and it's activated by it's essentially related to orthostatic tachycardia, and nausea, and if the headache is present, it actually often tends to be migraine in nature rather than orthostatic, but these patients can certainly have orthostatic headache as well. And the mechanism is not well designed, but one theory suggests that there's a reduced venous return to the heart in the standing position, resulting in reduced spinal venous pressure, which results in reduced CSF pressure as CSF is absorbed through the venous circulation. So in terms of the diagnosis, it's a sustained heart rate increment greater than 30 beats per minute within 10 minutes of standing, or the head tilt-up test that can be done. Sorry, I just need to advance. If you could advance the slide, please. All right, so in regards to the association with POTS, thank you. It may be associated with orthostatic tachycardia in patients that have spinal CSF leak, but this appears to be caused by deconditioning. So there's a reduction in that venous return to the IVC, leading to epidural venous hypotension, and then that can resolve when there's SIH treatment that's performed. And then other times patients may have POTS that's worsened with SIH. So they actually have underlying POTS, but it worsens with SIH and does not resolve with SIH treatment. So that's a little bit different in the patients that have secondarily developed orthostatic tachycardia. And the combination of SIH and POTS may be seen more commonly in patients that have connective tissue disorders. Okay, there we go. So in regards to differentiating the two, it should be suspected when there are symptoms that are not typical of SIH or cervicogenic headache. So if patients have more prominent things like palpitations, tunnel vision, hyperventilation, shortness of breath, anxiety, non-headache symptoms, postprandial malaise, things like that, it tends to be more likely POTS than SIH. My personal experience is that in POTS, that orthostatic dizziness, presyncope, and palpitations and fatigue tend to dominate. And then when headache is present, it's usually not the most disturbing symptom. In regards to SIH, though, the headache tends to predominate in the majority of patients, and they tend to also have more disturbances of balance, ear-related symptoms like muffled hearing, underwater, non-pulsatile tinnitus, a lot of the things that Dr. Mansour mentioned, and other neurological symptoms. One interesting thing is that there was a study that was done looking at the size of the optic nerve sheath diameter, and it found that it dynamically decreases during upright posture in SIH, but it doesn't do so in POTS, actually. Whether those patients have orthostatic headache or not, there was no change in their optic nerve sheath diameter. So that's actually helpful as well, in that hopefully over time, not just with clinical features, but with some of these other additional diagnostic imaging features, we can help to differentiate the two. All right, so let's talk about lumbar puncture opening pressure. So as we've already discussed, lumbar puncture opening pressure is not recommended as a diagnostic tool for SIH unless there's actually doubt about the diagnosis. So if there's other diagnoses that are being considered and CSF analysis is felt to be helpful, then it should be done. But generally, we don't recommend it as a diagnostic tool for SIH. And many patients with SIH will have normal opening pressure, as we've discussed, and this has been illustrated by multiple studies. Even if an LP is performed, a low CSF opening pressure can help confirm the diagnosis, but if it's normal, it does not rule out the diagnosis, as we've discussed. And so some of the reasons, Dr. Mansour already discussed this as well with Kelly-Monroe hypothesis, but the pathophysiological mechanisms that are present, like venous engorgement, may allow some of that pressure to normalize in some of these patients, even though they still have that underlying condition. And there's a wide range of opening pressures that are considered within normal range. Even if there was some relative drop in a given patient, we may not know that because we don't know their pre-SIH opening pressure. So perhaps there's a bit of a drop in some patients, but because there's that wide range of normal, it may be hard to differentiate. All right, so in regards to disability and quality of life, so this is definitely a considerable cause of morbidity and disability for patients due to both physical and mental health symptoms. And these are some of the recent studies that have been done. So there was a study at University of Bern that looked at 79 patients that had confirmed SIH, and it was found that over 30% of patients reported severe impact in their partnership. Over 40% had moderate or severe impact on their social life, and over half of patients reported sick leave for more than 3 months. And even when patients were treated, if they still continued to have residual symptoms, they still showed significantly impaired health-related quality of life compared to those that were successfully treated and were asymptomatic. Another study at the Medical University of Vienna of 86 patients also found quite significant issues. So, a lot of patients reported depression, about 78%. Nearly all patients reported anxiety. Disability was very high, so you can see here 40% reported severe disability, about 20% moderate disability, so very large numbers, and over 2% said they were completely disabled and could not do anything. In regards to impact on employment, 15% were able to work full-time, but that was only 15% of patients. The rest had either to work part-time, or about 30% were unable to work, and about 60% had to retire early due to SIH. So very significant morbidity related to this. And then this is another well-known study by Dr. Friedman's group at UT Southwestern. So this one involved 95 patients, where 59 were confirmed as having SIH and 36 were clinically suspected. And they completed validated questionnaires. And you can see here again, very severe scores. So HIT6, which looks at headache impact, 75% scored within the most severe headache category. SF36, which looks at quality of life and wellness. Again, many patients reported significantly low scores on this, lower than reported actually for patients with MS or even IIH, intracranial hypertension. PHQ-9, which looks at depression, about half of patients scored in the moderate depression range. And for GAD-7, about a quarter of patients reported severe anxiety. And they also looked at another scale that looked at spiritual well-being during chronic illness. And again, these patients scored very low. In symptomatic cases, when they were compared to patients with AIDS or cancer, they scored lower. And of 67 respondents that completed the Columbia Suicide Rating Scale, 64% indicated a wish to die, and 22% had demonstrated suicidal behavior. So again, very, very severe impact. But the good thing is once patients are treated, especially successfully treated, outcomes actually return to normal essentially, and these patients demonstrate similar to the general population in regards to these scores. All right, let's briefly discuss the long-term complications. So as was already mentioned by Dr. Mansour, there can be a number of complications that are seen with especially long-standing spinal CSF leaks. So coma may be seen, especially if there's severe brain sag or brainstem compression or herniation. Frontotemporal dementia was already mentioned by Dr. Mansour, but this again is a potentially reversible cause of dementia, so very good to take a very careful history and also do appropriate imaging. But these patients often present with behavioral variant changes, and they also have frequent daytime hypersomnolence, so very drowsy with behavioral issues. So if you see that, definitely think about this on the differential diagnosis. And then in regards to ventral CSF leaks, particularly superficial siderosis, infratentorial superficial siderosis can be seen. And this can present with hearing loss, cranial nerve deficits, ataxia, and more often seen with ventral, although it can be seen sometimes with other types of leaks as well, but predominantly described with ventral CSF leaks. There can be non-aneurysmal subarachnoid hemorrhage. Etiology of this is not clear, but potentially thought to be related to increased arterial pressure and stretching. Spinal cord herniation has been described in about 1% of chronic long-standing CSF leaks, more commonly seen in women than men. And then bibrachial amyotrophy, which presents essentially like ALS, amyotrophic lateral sclerosis, but atrophy and weakness of the upper extremities, more commonly seen in men, and again, more commonly seen in patients that have ventral CSF leaks that are often long-standing. And then the last is brainstem infarction. Again, the mechanism is not clear, but felt to be potentially related to compression or stretching. And the important thing is that early recognition and treatment can actually prevent these complications. So if we treat these patients and diagnose them early, hopefully we can prevent these complications. And also there's data emerging now that earlier treatment can also halt progression and sometimes even improve symptoms. So even if a patient is found to have superficial siderosis, for example, and they're found to have a ventral dural leak, it's never too late to treat because these patients can actually improve and it can certainly halt their further progression of these complications. So reasons not to miss a diagnosis. We've already alluded to a lot of this, but this is a significant cause of morbidity, disability, and suffering. So definitely important not to miss because these patients are out there suffering, unfortunately, with high degrees of disability. They miss work often. They can't take care of their families. They miss school. So again, important, to reduce that morbidity and disability. And along with that goes that poor quality of life, unfortunately. So the earlier we're able to see these patients, diagnose them, and treat them, hopefully we can reduce that disability as much as possible. In more severe cases, it can be fatal as well, as we discussed, due to coma, for example, related to brainstem herniation or severe brain sag. And if unrecognized or untreated, we've discussed some of these long-term complications that can occur, like frontotemporal dementia, bibrachial amyotrophy, and superficial siderosis. And importantly, it's a treatable condition. So in most cases, we can treat this condition, and for many patients, it can be a cure, actually. So again, important to diagnose and treat early. So lastly, in summary, we've discussed that SIH diagnosis can be challenging due to overlap with other headache disorders. Diagnostic criteria, because unfortunately they have low sensitivity at this time, can be challenging for some physicians. So remember that they're specific, but they're not sensitive. Patients can have normal imaging findings, and it can be difficult in regards to access to care, but hopefully over time, as we're providing more education on this condition, we improve our diagnostics and hopefully improve our access to care. This can improve. In regards to differential diagnosis, just remember the common things that can present with orthostatic headache, so POTS, cervicogenic headache, and conditions that affect lumbosacral compliance. Lumbar puncture opening pressure is not recommended as a diagnostic tool for SIH, as we discussed, because it can be normal in many patients. It's a highly disabling disorder with potential long-term complications that we've already discussed. So again, important to treat it in a timely manner. And as we mentioned, it's a treatable condition, and many patients can be cured. Thank you very much.